So the next talk is by Florence Momplaisir. I hope I'm pronouncing it correctly. She's an assistant professor at the University of Pennsylvania, also in the Division of Infectious Diseases, Vice Chief for Equity, Diversity, and Inclusion in that division, and Senior Fellow of the Penn Leonard Davis Institute for Health Economics. Her clinical research focuses on improving health outcomes for women living with HIV and on reducing racial disparities in health outcomes. Recently, she has focused her efforts on addressing racial disparities in COVID-19 outcomes among healthcare workers, among hospital patients, and individuals living in historically under-resourced communities. Her title is Addressing Racial Disparities in the COVID-19 Continuum of Care from COVID-19 Testing to Treatment. So go ahead and share your screen.
Thank you so much. Please share screen. Can you see my PowerPoint?
Yep, just needs to go into slideshow mode.
Okay, wonderful.
Perfect.
Okay. Thank you so much. It's great to follow Dr. Pulit, who's I have a lot of respect for. So again, I'm just going to go straight to my talk. This is the title, Addressing Racial Disparities in the COVID-19 Continuum of Care from COVID-19 Testing to Treatment. So I have no conflict of interest. So I'm going to start by providing the epidemiology of the pandemic around the time study period that I'm going to present right now, and also provide a inequity framework to help us sort of conceptualize the way that we can identify points of weakness, or what I call inequality generating points, where if people fall off, they develop worse outcomes. And obviously, these are opportunities for intervention in order to achieve equity in COVID-related outcomes. And here I'm going to focus on testing, hospitalization, and in-hospital mortality, and end with implication for results. So we know that the pandemic has affected every racial and ethnic groups around the globe. However, in the US, racial and ethnic minorities and individuals of lower SES groups have been disproportionately impacted by COVID-19. And we also know that the virus itself doesn't discriminate, but as we know, the pandemic exacerbates existing health inequities. It really sort of flares those inequities that have long existed in our society and in the healthcare system. And we also know that social inequities complicates COVID-19 control. A robust public health response requires public health measures focused on addressing inequity generating points, and I'm going to go over what this means. And here I'm referring to race and ethnicity not as a biological variable, but instead as a proxy for the lived experiences of individuals under a societal system of racial stratification, which generates differential outcomes due to differential access to resources. So we have a public health system that's responsible for the welfare of individuals, and a healthcare system that's responsible for treating those who are sick. And in the case of COVID-19, after being exposed to the virus, it's important to have access to affordable and accessible COVID-19 testing, and to be able to self-isolate if one is positive, and monitor the symptoms. And if the symptoms progress to being moderate to severe, to have access to quality care in order to achieve a full recovery and avoid death. However, there are inequity generating points across this continuum that could accelerate the pathway to death away from recovery. And these factors, particularly for racial and ethnic minorities, include overcrowding in households, type of occupation, mode of transportation, income inequality, and residential segregation, which increases the risk of exposure to COVID-19. but also differential access to healthcare resources and biases in the healthcare system. And for those who are hospitalized with COVID-19, particularly for racial and ethnic minorities, the increased risk of disease severity due to comorbid condition and also biases in the healthcare system. So here I'm showing a curve of the pandemic during the study period, which took place between March 2020 to March 2021. And as you can see here, the second wave and subsequent waves we saw a sharp rise in the number of cases, but they were also associated with multiple changes in treatment guidelines, but also with testing strategies. So we saw the indication for testing to being loosened over time, and also availability of tests being more widely available. In November and December of 2020, we started vaccinating individuals following the use of monoclonal antibodies. Both are interventions that have been shown to decrease disease severity and decrease the risk of hospitalization. And in the hospital, there's been multiple changes in treatment protocols to treat individuals who are critically ill with COVID-19. So the point here is that there's a lot of temporal trends that occur during our study period. The objective of our study was to characterize the association between race and area-level social vulnerability with COVID-19 testing positivity, hospitalization due to COVID-19, and mortality due to COVID-19. And we stratified our findings by waves of the pandemic. So we obtained hospital and outpatient data from the Penn data warehouse using the UPHS system, which includes 6 hospitals. And for our study, we completed a retrospective cohort analysis using outpatient and hospital record data between March 2020 and March 2021. We created 2 cohorts. One was the testing cohort, which included individuals with outpatient testing for COVID-19 in the UPHS system, and patients who were admitted with a COVID-19 diagnosis. And our primary outcomes were COVID-19 testing positivity, hospitalization with a COVID-19 diagnosis 2 weeks before or up to 4 weeks after having a positive test, and a 30-day all-cause mortality. So individual exposures included race, ethnicity as defined here, and the neighborhood exposure. We used the Social Vulnerability Index, which is a measure established by the CDC for disaster relief efforts. And it combines 15 census tract indicators for SES status, minority status, age and disability, and housing and transportation. So with those neighborhood measures, we were able to create a score for each observation. So we started with descriptive statistics in the first and subsequent waves. And we linked data from neighborhood exposures using the American Community Survey to create the SEI score for each observation. And we used multiple logistic regression models of individuals nested in neighborhoods to assess disparities in testing positivity, hospitalization, and 30-day in-hospital mortality. And all models were adjusted for age, sex, and location of hospitalization. So we obtained data from over 350,000 COVID-19 positive tests and removed individuals with incomplete data, and we also removed duplicates, and we ended up with a sample of 225,000 for the COVID testing cohort. And for the hospitalization cohort, we included all hospitalization with the COVID-19 flag, which was an infection control measure used in the hospital to identify those with COVID-19 for infection control purposes. Again, after removing incomplete data and duplicates, we ended up with an analytic sample of over 5,000 observations. We decided not to use a longitudinal data analysis, but instead captured the first observation for hospitalization or for testing in order to address questions related to independence of observations. So for the demographic characteristics, for the testing cohort, as you can see, there were over 60,000 tests done in the first wave, and the numbers doubled or more than doubled in the second and subsequent waves. And we see a similar trend for hospitalization. In terms of the age distribution between the youngest individuals of age 80 and older, the distribution was about a third. The majority of the sample was female sex. The majority of individuals getting tested and were positive for COVID were mostly white and non-Hispanic. However, the majority of individuals hospitalized with a diagnosis of COVID-19 were Black non-Hispanics. And although Hispanics only comprise 5% of the testing sample, they comprise 11% of the hospitalization sample. We saw similar trends in the second and subsequent waves. However, there was a sharp increase in hospitalization non-Hispanic whites in the second and subsequent waves. As you can see, the hospitalization rate was 29% in the first wave compared to 43% in the later waves. Now, in terms of neighborhood, there was a lot of diversity and representation from a large number of neighborhoods, both for testing and for hospitalization in the first and the second waves. But it's important to note that the majority of patients resided in high SVI neighborhoods. So they were neighborhoods that were deemed to be socially vulnerable. So now I'm going to transition to the findings from the COVID-19 testing cohort. This is a map of Philadelphia, just for illustration purposes, although we did consider all UPHS hospital systems. I'm just showing in general that there was great penetration of testing around the Philadelphia region, but particularly in South and West Philadelphia. Now here I'm presenting the results of our multi-logistic regression models showing the association between race, ethnicity, area level social vulnerability, and testing positivity for COVID-19. And in general, a value more than 1 shows that the odds of being positives are higher if the confidence interval does not include 1. That is a significant finding. So as you can see here, compared to white non-Hispanics, all racial and ethnic minorities were at increased risk of testing positive for COVID-19. And this was seen in the first, second, and overall, for the overall results, which combined the first and second waves. We also see a similar trend for individuals living in high SVI neighborhoods. Now moving on to the findings from the COVID-19 hospitalized cohort. Again, showing a map of Philadelphia with the distribution of individuals who were hospitalized with COVID-19. Here I'm presenting the results of our regression models showing the association between race, ethnicity, and being in a social vulnerable neighborhood with the 2 hospitalization outcomes, so risk of hospitalization and a 30-day in-hospital mortality. So previously to what we saw with the testing cohort compared to white, non-Hispanic, all racial and ethnic minorities were at increased risk of hospitalization. And we saw a similar trend for individuals living in high SVI neighborhoods. But to our pleasant surprise, we did not see a similar pattern for the 30-day in-hospital mortality. So for the first wave, there was no racial differences. And for the second wave, Hispanic and Asians had a higher risk of mortality compared to white individuals, but this was not significant in the overall analysis. So in conclusion, we found that there's increased testing positivity and increased hospitalization for racial and ethnic minorities and individuals living in high SVI neighborhoods. However, there were no consistent differences in mortality by race. So the absence of disparities for in-hospital mortality could be due to the fact that UPHS protocols have been developed for escalation of care that are applied to all patients, reducing the risk for provider bias. And our findings are consistent with studies done in California, Michigan, and the VA, showing no differences in mortality by race or SES status for patients admitted with COVID-19. And the implementation of protocols in other settings within UPHS has also resulted in the reduction of racial and ethnic disparities. And this was seen for cardiovascular outcomes for women in the postpartum period. But unfortunately, what we did see is that inequity generating points are still occurring even in the later waves at the community level, resulting in higher testing positivity and hospitalization for racial and ethnic minorities and for individuals living in high socially vulnerable neighborhoods. And we know that it's really hard in high SVI neighborhoods, particularly for individuals living in multi-generational homes or who are frontline workers, to really have to implement mitigation procedures to preventing exposure to COVID-19. It's really hard to self-isolate, for example, in a multi-generational household. So there's less control there. However, there are effective interventions that exist to prevent COVID-19 hospitalization, and they include vaccination, as Dr. Pulit just talked about, and also the use of monoclonal antibodies in the setting of early COVID-19 infection. And I think that more work needs to be done to lower the risk of hospitalization by implementing these evidence-based interventions at the community level. So our study has several limitations. One is that changes in COVID-19 testing and treatment guidelines may have affected our results. We try to adjust for that by stratifying our analysis by waves. And the data that we had was limiting to examining in-hospital mortality. We were unable to ascertain mortality that occurred outside of the hospital. So it's possible, for example, that Hispanics and Blacks were more likely to die outside of the hospital compared to in the hospital. And there may be selection biases based on the place of hospitalization, which may differ by race, ethnicity, or SVI status. We saw a sharp increase in white non-Hispanics being hospitalized with COVID-19 in the second wave, and it's hard to know for racial minorities, for example, if they were more likely to go to another hospital compared to UPHS-based hospitals. Finally, I'd like to thank my collaborators, particularly Dr. Osama Bilal, who really led all of the geographic information system analysis for this project, and the Penn Data Warehouse that provided the hospital records or data in order to perform this analysis. And that's all I have. Thank you so much.
Am I on? Yeah, I'm going to ask you to just wait a minute because it looks like the questions are very delayed. Now I see questions for Dr. Pulit. So let me just read the comments for her, and then maybe by that time your questions will come for you. It's kind of weird. Okay, so 2 comments. Wonderful talk from Jeff Gerber. Dr. Pulit, much appreciation for your leadership. And from Anonymous, really wonderful talk. Any insight into how those of us in research rather than medicine might help to educate without taking over any lived experience, without talking over any lived experience. And one question this is to think about since we're done, she's been done. Has the Penn approach that you described been adopted by any other health systems? So I'm just concerned that these questions are taking so long that when we stop, there's going to be questions for you, I think.